Okay, Mark, go ahead.
Okay. Good afternoon, everyone. Thank you for being here today or whenever you might be watching this recording. This webinar is part of a series by the Project Better Together effort led by the Iowa City Area Business Partnership, the Iowa City Downtown District, the Iowa City Area Development Group, and Think Iowa City. Their teams have come together to do all they can to lead our local communities and economy through this pandemic. We would ask you to please go to icareatogether.com. That's icareatogether.com to learn more about what you can be doing to get involved. Specifically, there is a holiday shop local program where you can win gift cards to local businesses just by shopping at local businesses. And yesterday we launched a new Adopt a Healthcare Worker program to provide some support and caring to our frontline healthcare workers at our hospitals, clinics, nursing homes, and home healthcare aides who are contending with the impacts of this virus every day. We know they are tired and feel like we have failed them. So if we can all do something little to show our support, along with making consistently better decisions around gathering and masking, we can get through this. A giant step towards getting through this pandemic is an effective vaccine. Today, we're here to talk about what is currently known around the leading vaccine candidates, the rollout plans, and answer your questions so we can all do a better job of, in Johnson County, of being a leader in adherence rates and getting to the other side of this. So we'd ask you to please use the question function and we'll try to get all of your questions answered. We anticipate having a follow-up session after the start of the new year when we're in the rollout phase and have some idea of what adherence rates look like. That's a hard word to say. We have a fantastic panel for you today, and our moderator is Dr. Rick Dobyns. This summer, long before any vaccine was ready, he was already had the foresight to start pulling groups together to begin discussing how we could effectively message and prepare for the rollout when the time came. Fun fact I learned today about Dr. Dobyns is that he was born on Birdrup Park Air Force Base in Roughton, UK. He has been a practicing family medicine physician with a focus on geriatric medicine at the UIHC for many years. And like many, right now has been asked to triage COVID patients. Rick is a tireless community volunteer serving on countless nonprofit boards and even served as a city councilor. As he told me, he can speak the languages of medicine, government, and bureaucracy. Dr. Dobyns, thanks for all that you've done for the community and for your patience and for your foresight in getting us to this point today so that we can get the best vaccine information out there. The floor is yours.
Thank you, Mark, for that introduction. That's great. This introduction webinar that we're having today has actually become much more important to me over the last few weeks because I myself, with the surge of COVID activity in Eastern Iowa, I myself now am starting to take care of our inpatients here at UIHC that have COVID-19. So all this information is not only generalizable for my colleagues and the public, but it's very important to me individually as well. We're going to have three different installments today. Primarily, we're going to be focusing on a question and answer session. I've told all the speakers today that just to assume that you all have listened to your favorite media platform this morning and you are as up to date and informed or confused about the COVID-19 vaccines. The speakers I have today first will be Pat Winokur, who's going to be discussing vaccine development, followed by a Q&A session for Pat. And then Mike Brownlee and Sam Jarvis are going to discuss vaccine distribution with a Q&A of their own. And then Aaron Scherer from the Department of Internal Medicine is going to be discussing vaccine non-adherence and mitigation strategies. So the first person I'd like to introduce today is Pat Winokur. I've known Pat for a long time, and Pat is a tenured professor here in the Department of Internal Medicine. She's a specialist in infectious disease. She's the executive dean of our Carver College of Medicine. Pat's done has extensive funding from the National Institute of Health on vaccine-related work. And I know that from her own clinical practice, when she started to see that she recognized that we had many known pathogenic viruses and emerging resistant bacteria, she saw a need to develop effective treatments, which informed her research career, which has been extensive. She reviews published research for many journals, the most notable of which is the flagship journal of our profession, the New England Journal of Medicine. She is the primary investigator of the Pfizer-BioNTech SARS-CoV-2 vaccine. That is the virus that causes the COVID-19 illness. So Dr. Pat Winokur, thanks for joining us this afternoon.
So thank you for having me. This is a really exciting time in the world of vaccines because we've seen unprecedented progress in creating a COVID-19 vaccine. That unprecedented progress, though, is something that I really want to talk to you about today. I think it has given people a lot of hope, and it should. Some people have taken it, though, as a concern that maybe these vaccines were produced too quickly. And I want to give you some information about why I actually think you should be a little more kind of calmed by how this vaccine strategy has rolled out. So when we test new vaccines, we have a very specified way that we test vaccines. And a lot of the work, a lot of the time is spent in understanding what happens in the test tube. And then once we understand what happens in the test tube, we create vaccines and we test them in animals. We do a lot of safety testing in the animals, and in the animals, we can actually test what happens when you challenge that animal with the infection that you're trying to prevent. Once we have that extensive test tube data and animal data, we start in very small numbers of humans in what we call a phase 1 study. This is usually somewhere between 30 and 80 people. And the goal really is to start testing safety. And we are very diligent with that safety testing. We're testing labs, we're doing physical exams, we're looking at electrocardiograms, all sorts of things to assess safety. Once we've satisfied ourselves that these are safe, we move into larger numbers of humans, usually somewhere between 100 and 300. This is phase 2. And in that stage, we are really honing in on the best dose and really the best vaccine. Always keeping safety in mind. And once we have a little bit of that early data on antibody titers or something that we're using as an assessment of efficacy, we move into the pivotal studies, which are phase 3. The key for the phase 3s is usually, under most circumstances, we are testing somewhere between 1,000 and 3,000 people. Keep that number in mind, 1,000 to 3,000 people. In that group of people, we are really honing in on efficacy because obviously we don't want to release something that doesn't work. Once that data is gathered, it goes to the FDA, and FDA can make a decision on whether this is a safe and effective vaccine. So how did we make all of this happen so quickly with the COVID-19 vaccines? And I think a lot of the story goes back in the test tube stage. And we were very lucky in a pandemic situation. That's an unusual word to use, but the fact that we have a virus, the SARS coronavirus 2, that is so similar to the SARS coronavirus 1 virus that occurred in around 2002, and then another related virus that was the MERS virus, which caused disease in the Middle East. There was a lot of science that had been done starting to develop vaccines for those two pathogens. We were lucky in those two timeframes that those viruses didn't end up spreading widely throughout the world. They didn't cause pandemics, but we were worried, and we were worried enough that we studied a lot of the virus, understanding what might be the best way to protect people. And we even created vaccines that were tested in humans. So when we identified the COVID-19 pandemic in December and January, we were already pre-prepared because of that previous data that we had. And people could develop these early vaccines very quickly. And we even had animal data on their safety. So once we had that knowledge, we could go into those early phase trials in humans very quickly. And that was, I think, one of the best things that happened in making these vaccines readily available in a quick time fashion. We also understood these new vaccine platforms because of a lot of work that had been done and figuring out how to purify them easily. How do you make them quickly? So now let's get into what we've seen. So the two vaccines that are in the lead right now are the Moderna vaccine and the Pfizer BioNTech vaccine. Both of these are similar platforms. They're messenger RNA vaccines. The good news about messenger RNA vaccines is they are quick to produce, and we have a lot of information on animals about their safety. These studies both enrolled 30,000 to 44,000 people. Remember I told you that our typical phase 3 study enrolls 1,000 to 3,000 people. We are 10-fold above that with each of these vaccines. That is really important. We have a lot of safety data now. But on top of that, we now have the early efficacy data. And what we were able to see with both these vaccines is they were about 95% effective in preventing symptomatic coronavirus infections. What that means, if you look at the Pfizer data, they had 170 infections. 162 of those occurred in the people that got placebo or salt water. Only 8 infections occurred in people who had been vaccinated. So that is a very successful vaccine, much better than I had even hoped. So when I saw those results, I was very excited because this really is the possible way that we can squelch this pandemic much more quickly. The safety data, when we are looking at vaccines, the most important thing that we're usually looking for is some kind of unusual immune-mediated result. This could be something like Guillain-Barré, which you may be familiar with from flu vaccines. It might be something else. Remember, we've tested 75,000 people with this vaccine. Half of them got drug. And there were no events in those trials that halted the studies. Now, I have not seen the intricacies of the safety data, but the fact that neither of these studies was halted is a really good sign. FDA will be evaluating the safety data intricately as they're evaluating it over the next week. So this is a really good result. And I think we have a lot of safety data. That immune-mediated disorder usually occurs in the first 2 months, and we were required to follow most of these people for 2 months before FDA would look at the data. So I think there's a lot of hope out there, and we're excited to have the opportunity to have the FDA looking at this data. What we have seen here at the University of Iowa, we enrolled 270 people. These vaccines do have reactogenicity. And by that, I mean, you feel a little punk for 24, 48 hours, fatigue. Some people will have fever, muscle aches, that flu-like feeling. Most people responded really nicely to Tylenol or ibuprofen. And then we're back to their normal selves the next day, or at most the day after. So I expect that it's something we see with vaccines. It's not worrisome. And I think we can expect that people will, with the right education, understand that this is a side effect that is associated with the vaccine, and it will stop and they'll get back on their feet exactly the way they were 24, 48 hours. So I'm going to stop there and let people ask questions. There's lots more we can talk about. So let's let you guys decide how you want the discussion to go.
Rick, I think you're muted.
Excuse me. Thank you, Pat. First question is, when will we start to know if the vaccine is effective in limiting transmission by those who have received it? Something I've heard is that the vaccine is going to change my genetic code. How can we best explain why this isn't the case?
Okay. So there are two things that we look for in a vaccine. One is, does it prevent severe disease? And the other is, does it prevent transmission from person to person? Oftentimes those two are a little bit linked. What we know from the data that we have seen that's been published in a fairly public forum is that we are preventing significant disease, symptomatic disease. We do not have great data on how it is disrupting transmission from person to person, but my guess is, knowing other vaccines and other viruses, this is limiting the viral replication and probably is going to limit spread. So that's a good question. We'll be learning more. The other one is a really important one. The question is, can this change my genetic code? So the messenger RNA vaccines do use part of our cell system. RNA is what encodes proteins. But the good news about these vaccines is that RNA is very unstable, which is a good thing in the sense that it is broken down very quickly in the cell, and it's broken down so fast, it cannot get integrated. And RNAs typically don't integrate either. So that's another good piece of information. So I don't worry about that. They've done a lot of studies in animals looking at how much RNA is left, and it breaks down very quickly. So that seems to be something we don't have to worry about.
Next question, Pat, is I heard this morning that 43% of the population will not take the vaccine. Dr. Scherer later on in this program will be talking about some mitigation strategies to reduce or optimize vaccine adherence. But the question is, could you talk a little bit about the impact wiping out the pandemic, sort of speaking to sort of the herd effect that people have heard about?
So the key is the more people we can get vaccinated, the more we can reduce that transmission from person to person. The other thing that's really important with vaccines is, in general, the very young and very old are less able to mount an immune response. And sometimes the best thing we can do to protect them, and this would be protecting your grandmother, protecting your newborn, is to really kind of surround them with vaccinated people. So there is a concept of kind of altruism. Is a vaccine, sure, it will help you, but it also helps your neighbors and those that are most vulnerable. So think about that. But really, I think the numbers are escalating. So you tell me 43% today, well, that was 50 or 60% last week and the week before. And I think what you're going to see is more people are going to have experience with these vaccines. People are going to be more comfortable as they see that their neighbors did fine, and that acceptance of vaccines is going to go up.
Pat, we've heard varying guesses as to what we need for herd immunity, population resistance to SARS-CoV-2, for us to be able to relieve ourselves of the pandemic precautions, businesses open up. That number has been talked about as 70, 80, even as high as 90%. How would you answer that question?
So I think that there's a lot of modeling that has been done to try and understand the effects of kind of squelching this pandemic. 70% is a great number to hang your hat on. The fact that this is a vaccine that's 90%, 95% effective allows us to get more of that protection around the community faster. So that's been a really good part of the data that's come out as well. But I would hope that we can get about 70% that take the vaccine. And that's, even if we can get 50%, as we start getting more people immunized, it's going to help more and more and more. So keep up the progress. Don't worry that we haven't reached that magic number today. Just keep going for tomorrow, and we want people to take this vaccine.
For the audience, we have plenty of time left with Dr. Winokur, so about 8 more minutes, so please keep sending in the questions. Some of the questions I'm going to move to the other speakers because they're a little bit more relevant. So Dr. Winokur, how long will the vaccine be effective for? A lot of us are concerned that, perhaps maybe this is something like the flu vaccine we'll have to revaccinate for every year.
So that is one of the things that we're going to be learning. We know coronaviruses, natural coronaviruses, are a little bit more short-lived in their immune response. One of the things that's also really good that we've seen in some of the published data is the immune response to these messenger RNA vaccines is about 4 times higher than what you get with natural infection. So that's really good because the higher immune response you can get right up front, it's going to last longer. I would guess that this might need to have booster doses, maybe once a year, maybe once every 2 years, but that's something that we will be learning.
So, Pat, a lot of us have heard that there's going to be multiple vaccine options available as the months go on. Some of the vaccines have used that method, and you referred to this as the messenger RNA method, that's never been used before on humans. These are the ones that have the report of 95% efficacy as opposed to maybe a lesser efficacy with the other vaccines. Shouldn't we, assuming we may have the opportunity later on to pick and choose, should we wait for the other ones that aren't quite as experimental?
So, I've thought about that one a lot. I'm comfortable with the safety of the messenger RNA vaccines. I obviously have the understanding of the science behind them, and I think they are very safe. My worry is that, honestly, they've set the bar so high with how effective these messenger RNA vaccines are, that it's going to be harder for these new vaccines that will be coming on later to meet that efficacy. I personally will be in line for the messenger RNA vaccines. I think these are safe, and you can't beat a 95% efficacy.
So, Pat, when you line up and you get your vaccination, you've mentioned that there might be a bit of a side effect profile. We've heard a couple of things. We've heard that older patients who've had the Shingrix vaccine, it can deliver quite a kick. Are the people who had that sort of problem with Shingrix more likely to have it with the messenger RNA COVID vaccines? And if so, should we perhaps get ready to give our employees and even ourselves maybe a day off after we get the vaccine?
So I don't think you can anticipate that because you had problems with one vaccine, you'll have problems with another. They're completely different antigens. The Shingrix vaccine, remember, it's based on the chickenpox virus. And some people have already pre-existing immunity, others don't. And so I would not anticipate an identical response. People often had side effects in the people that we've studied, but the vast majority of them continue to work the next day. They noticed that they were a little bit off, but it didn't disrupt their day-to-day activities. We did have a few that had higher temps and were a little bit more fatigued to the point that they wanted to stay off, but the vast majority did not. So I think it's very individualized, and you'll have to watch for each individual to see their response. You will have a slightly more robust response with the second dose. And that's something that people can anticipate, and that's something that we've seen in the studies.
You mentioned before that the phase 3 trials have gone on for like 5 to 6 months, depending on the specific vaccine. How do we know in humans if after 5 months, when it's widely distributed, that people won't start to have problems that because of the length of the phase 3 trials, we just don't know about?
So this is something that was very carefully decided by the FDA when they decided what the criteria would be for evaluating data for emergency use authorization. And they picked 2 months follow-up after the second dose of vaccine. And that was very intentional because we know that almost all of these unusual side effects from vaccines occur in the first 2 months. So under normal circumstances, no pandemic, a common disease that just happens, sporadically throughout the year, we would have taken probably 6 months to watch for those side effects. But I think when you have tenfold the number of people studied and you follow them for 2 months, you've actually enhanced the safety follow-up beyond what you would normally see in a run-of-the-mill vaccine trial.
Next question is, let's say I'm healthy, I'm 20, 30, 40 years of age, and I've had or been told I've had the COVID-19 infection myself. Darned if I knew about it because I really didn't have much in the way of symptoms. And now it's like April, it's May. And all the at-risk people have been vaccinated in various ways. And let's say perhaps 60% of the population has been vaccinated. I had COVID-19. Why should I get vaccinated?
So I think this is the opportunity to actually get that higher immune response. The natural infection, and especially in some of those people who are a little bit more asymptomatic, may be a little bit low. And so getting the vaccine is going to boost your immune response pretty quickly. And I think will be advantageous for protecting you for a longer period of time.
The vaccines aren't for children. However, we do know that children, depending on the age, can definitely get the infection, can spread it. And we've heard that sometimes they're the most problematic because they can give it, they spread it, they hug and kiss everybody, but we don't know it. What is the theory about eventually vaccinating children and infants?
So we don't have the data yet in children and infants, but we will be starting those trials as soon as we can, because that's a very important population. And this is very much like influenza. It really is that in vaccinating some of those people that are out in the community and are running around in schools and stuff, that often does protect the elderly really well. So I think it will be that there will be vaccines available for children, but they're not approved yet. Well, none of them are approved yet. I think first we'll have approval for the adults. Pfizer, remember, did enroll kids between the ages of 12 and 17. So we may have some data from the Pfizer vaccine for those teenage kids. And then we will need to expand into younger kids.
Dr. Winokur, thank you so much. The questions, everybody, were great. The answers were fantastic, extremely helpful in letting us all know. So I'd like to thank Dr. Pat Winokur for providing her knowledge and expertise, and especially your leadership in developing the Pfizer-BioNTech vaccine for use for all of us. Dr. Winokur, thank you very much for your time.
Thank you.
So our next speakers will be Mike Brownlee and Sam Jarvis. Mike is the Chief Pharmacy Officer and the Associate Director of the UIHC. Mike's a native Iowan. He obtained his Doctor of Pharmacy degree here at the University of Iowa, and he traveled away to the Oregon Health Sciences Center in Portland, and we were very lucky to get to steal him back, so thanks, Mike. Mike is joined by his partner in getting us protected from the COVID-19 here in Johnson County, Sam Jarvis. Sam is a graduate of Knox College in Western Illinois, and then he went close by and got his master's in health science from Western Illinois University. Before he came here, he was at the Knox County, Illinois, serving in public health there. and he has recently moved and given a major leadership position, especially during a pandemic. Note to all, you don't want to be an epidemiologist in the midst of a pandemic, and I think Sam has found out that keeps him very busy. He currently works as the Community Health Division Manager for our Johnson County Department of Public Health, and he will soon become a very familiar voice and face to all of us. So he and Mike Brownlee are going to discuss the vaccine distribution. Thanks, guys.
Thanks, Rick. I think Sam's going to get us kicked off first. Are you okay, Sam?
Yeah, sounds good. Did everyone see my screen? Slide deck, good to go? Sounds good. All right. Well, again, thank you for having us and having the ability to share what we've been doing behind the scenes with vaccine planning. You know, early on, mid-September, the state had announced their internal planning team and invited us to be part of that. And so roughly every month, we've been sitting in on meetings with them as well as other partners. And then certainly extending that locally to groups that we work with and have been working with throughout the entire pandemic. A large part of that strategy has been you know, revolving around vaccine provider recruitment. And that's utilizing really the existing infrastructure that's already in place to deliver vaccines. And so a large part of what we've been doing is sharing information with partners who already perform vaccinations and keeping in close touch with them as more information comes out. As everyone can imagine, every day, week, by the hour, information is changing pretty quickly. And so keeping everyone on the same page has been quite the challenge, but we've got a team here internally as well assisting with that. Other parts of that strategy is looking at the future as well with more public and open vaccine planning. And so we've had staff here and a huge thanks to our partners at Johnson County Emergency Management Agency, the Visiting Nurses Association, and volunteers to perform different modalities in terms of vaccine clinics. One of those, as some of are aware or can imagine, are drive-through vaccine clinics. Some see those pretty commonly with flu vaccines. It provides pretty quick service, and certainly, given the concerns with COVID-19, provides the ability to physically distance and keep persons separated. Other parts of the planning that we've been doing behind the scenes is looking at streamlining a lot of the processes. As many are aware, the situation that we're in now with the vaccine candidates, they have, excuse me, very stringent cold chain requirements. And certainly the state and our federal partners are also requiring pretty narrow timeframes for reporting. And so we've got a lot of layers of complexity that we're working out with our partners in terms of planning and then communication. The other part of that, as everyone can imagine, is looking for staff and volunteers to assist with other vaccine planning in clinics. And so we've been actively recruiting for our Medical Reserve Corps volunteer unit here that will help assist as we go out and venture into the community and assist other facilities with vaccination in the future. Again, there's a lot of information coming out very quickly, and we can anticipate December being very much the same. And so we'll have a lot of information to share with our community partners and the community at large. One of these being this webinar right here, which we appreciate the opportunity. Again, as we learn more about the complexities of this vaccine and distribution, we'll be looking at different strategies and timing, what allocation will look like specifically and distribution from when we digitally allocate it, the shipment to site and facility, and then the administration of it to staff and residents and others. Other parts of that communication also involve local agreements, or what we'll refer to as closed point of dispensing agreements with facilities who are able to provide the vaccine for their staff and themselves. So a good example would be our long-term care facilities and assisted living facilities that have that medical capacity and the ability to do so. And probably and mentioned previously, a lot of coordination. The state has asked us to be operationally ready by mid-November and going forward. And so as we learn more and as we continue to coordinate with partners, we'll continue to look at what public vaccination will look like in the future. But here depicted on the slide is a snapshot of our drive-through flu clinic at Johnson County Fairgrounds. Again, a huge thanks to our partners. But as you can see, and many are aware in the area, Fairgrounds provides a pretty large footprint for a good amount of intake of persons. The fairground buildings provide cover and some environmental protections. So we are thinking of all hazards, all seasons, all different types of weather situations and scenarios. And so going forward, we'll continue to explore different methods on how to deliver a vaccine. And as always, working with our partners for allocating vaccines to different providers within Johnson County. In terms of vaccine provider agreements, we do know that the state's approved roughly over 1,000 different providers across the state. We know that all 99 public health departments are part of that. We know a large majority of long-term care facilities are part of that, and every day and week that number continues to grow, and should really assure people that the state is marching to one beat, and that we're utilizing the existing infrastructure to deliver vaccines as quickly and safely as possible. So, and with that, I'll turn over to Dr. Brownlee.
All right, thanks, Sam. I'll share my screen. I've got a couple of slides to share. And just want to make a comment to really appreciate all of the help from Johnson County Public Health as a provider in the area. I think they've done a fantastic job working with the Department of Public Health. So we're grateful for their partnership and their leadership in this area. And I think they're going to help us be very well prepared for upcoming vaccination. All right, so. Can you see my screen okay?
Yes.
Okay. I'm going to spend just a couple of moments talking about the COVID-19 vaccine itself. So as has been mentioned, we're in a new era from a vaccine perspective, new types of vaccines, new requirements from a storage perspective. And the two leading candidates that we have right now are the Pfizer candidate and the Moderna candidate as well. So if you don't check the news daily, it's changing every minute, every day. Even as of this morning, the UK just approved the emergency use authorization for the Pfizer vaccine. And I think they intend to start vaccinating within the next week. So that's exciting news. We did have news this week, with this past week, that Pfizer had started to pre-deploy some of that vaccine into the United States from their production facility in Belgium. And so that's the picture on the left. And I'll talk a little bit more about the storage requirements in a second. And then Moderna had submitted for their emergency use authorization as well. So the Pfizer candidate will be reviewed on the 10th of December, and we'll know shortly after that if it's been approved. And then Moderna on the 17th of December. So exciting times, exciting couple of weeks coming up. I think this is really timely to help answer questions that many have related to vaccines, because we want to be transparent. We want everyone to understand what are the nuances, what are the differences of these vaccines compared to others that we've had in the past, because they are so new, and because the timeline has been much more expedited than those in the past. But I think Dr. Winokur really helped us to understand more about how we're ensuring the safety of these vaccines moving forward. So as we look at these unique storage requirements, so the Pfizer candidate specifically is to be stored between -60 and -80 degrees Celsius. And so I have a picture of an ultra cold storage refrigerator here, a freezer. So the doses actually have to be transported to us in dry ice. So the picture you see on the right, the boxes themselves, if you look at the grid box there, think of it as each layer is the size of a personal pan pizza. So 9 by 9 inches by 2 inches. Each one of those small boxes holds 975 doses. So this is unique for us, that inside that box, there are 975 doses. Each of those vials will serve us with 5 individual doses. And so this is really unique for us. And I know there are a lot of questions around the transport, not just to areas like Johnson County where we may have ultra cold storage, but what do we do about the rural areas as well? And so on this slide, I've just outlined some information about the Pfizer specific candidate. But even with the Moderna candidate too, it has to be stored at -20, so at a regular standard freezer temperature. And I'll talk about that more in just a second. So as we look at the Pfizer BioNTech product, we have to take that out of that ultra cold storage and thaw it for 30 minutes. This is not like other vaccines that we have. When we talk about a flu campaign or the flu vaccine, those are in pre-filled syringes. They're refrigerated. It's easy to manage, easy to store, and it doesn't require a lot of manipulation. In this case, each of those small vials will have 5 doses that we have to thaw, reconstitute, and draw those out at that time. So much more of a complex process than what we're used to with other types of vaccines. So the other thing to think about too, with these types of vaccines, the mRNA specifically, is they might not quite be as stable longer term as other vaccines. So with the Pfizer product specifically, we have 6 hours once it gets reconstituted. So once you add saline to that vial, reconstitute it, we then have 6 hours to use it, even if you put it back in the refrigerator. If you take it out of the ultra cold storage freezer, you have 5 days in a refrigerator before you can reconstitute it and use it. So much more strict requirements. On the Moderna side, it's stable for 6 months in the freezer, is what we know at this time, and 30 days in the refrigerator, and you don't have to reconstitute it. There are 10 doses per vial for the Moderna vaccine. And I think one of the learnings that we have is that as these different candidates come through, they're gonna have different requirements from a handling perspective, and some may be more stable for longer at different temperatures as we think about how to get vaccine out into more outlying areas where they may not have ultra cold storage. They might not have access to dry ice to recharge those boxes that can store the vaccine. And so we're working through that at least now at this time. And we may find over time that as Pfizer starts to evaluate the stability of the vaccine product, they may give it a longer duration to be either out of the freezer or in the refrigerator. So that may change and make that more stable. They may assess that stability so that we can use it in other more outlying areas. The supplies that we'll receive from the federal government will come separately, but we will have supplies that will help us to be able to administer the vaccine. So a lot of differences when we look at the different types of vaccines, a lot of more tracking too, because this is a 2-dose series, at least both the Moderna and the Pfizer. The Pfizer vaccine doses are separated by 21 days, the Moderna separated by 28 days. So we're gonna have to work really closely with tracking, the reporting up through the IRIS system, and making sure that we can get maximum efficacy out of these doses of vaccine. So when you look at the studies and the submissions to the FDA for those high efficacy rates, it's 7 to 14 days after the second dose. So we want to remind everyone that you're going to get the most efficacy out of these vaccines after receiving the second dose. You'll have some immune response to that first dose, but just because you had maybe a reaction to the first one, we don't want you to skip the second one because you're going to miss out on maximum efficacy. So just yesterday, there was an emergency meeting by the Advisory Committee on Immunization Practices within the CDC. They had that meeting to start looking at prioritization of the vaccine. And down in this slide, you can see phase 1A, at least in their preliminary vote yesterday, they will meet again. If the FDA approves on the 10th of December, they'll meet again to finalize their recommendations for prioritization and allocation of the vaccine. But healthcare workers are in that first phase. And also long-term care facility residents. So that's what we know at this time, at least where it's trending toward from a prioritization perspective. This is all public information as of this meeting yesterday. And we know that at least from our health perspective at UI Healthcare, as healthcare providers, that we're ready in that first wave to start the vaccination. We're ready for that storage, and we're ready to partner with Johnson County Public Health and Iowa Department of Public Health to help support us in getting vaccine out and maximizing the uptake of vaccine, not just in Johnson County, but the state of Iowa. So with that, those are all the slides that I had. And I think we're happy to answer any questions that you might have related to the vaccine or the planning that we're planning in Johnson County.
Mike, Sam, thanks for that. The first question that we have for you today is alluding to the fact is that it sounds like the first two available vaccines will be the messenger RNA vaccines that require some level of cold storage. The CDC, as you mentioned, Mike, came up with some recommendations that we should prioritize not only frontline healthcare workers, but residents of long-term care facilities. You noted that the Johnson County Fairgrounds is going to be sort of an epicenter for some vaccine distribution, but because long-term care facility residents are frail, it's difficult for them to get there. And it looks like the difficult to transport vaccines are going to be first up for them. How are we going to get our local nursing home residents vaccinated?
That's a great question, Sam. If you want to jump in too, I know that there's going to be a partnership with long-term care facilities and community pharmacies. I believe the agreement right now is with CVS and Walgreens to be able to help manage that. I know that they're going to have the cold chain managed well to be able to get, if the Pfizer vaccine is first, which we expect it to be, that they can manage that effectively. So that will be in partnership with community pharmacies to manage the immunization of long-term care facility residents.
Absolutely. And, you know, through our communication and information sharing with our partners, long-term care facilities specifically, we've encouraged all of them to sign up for that opportunity, as well as be providers themselves for their staff and those local agreements that we mentioned before. So really, when we look at this for the population that's pretty vulnerable to this disease, we've got multiple redundancies in place to ensure that we can deliver a vaccine to them. So.
Next question, as far as distribution is concerned, when we mentioned, does the state of Iowa get a certain amount of vaccines, or is it by region in Iowa, or is it by county? How is that determined?
From what we know and from past experience, majority of vaccine or other medical countermeasures are distributed pro rata by population. So to our knowledge, that they'll be distributed among states based on population.
Since Johnson County has an inordinate amount of healthcare workers, frontline healthcare workers, do you anticipate we're going to have enough for frontline healthcare workers and long-term care facility residents here in the Johnson County region?
Initially, I think the supply will be somewhat limited, but every day, every week that goes by, we'll see more and more.
Is there a prioritization method set up on, which subgroup within the groups get in line first?
That again, that's a great question for each facility as well. Certainly healthcare professional and facility staff cover a wide variety of professions and careers. And so again, we'll be looking at and coordinating with our partners with the state's guidance to really narrow down exactly who, and certainly develop those strategies to be able to reach everyone as quickly as possible.
Yeah, just to add to that, I think the ACIP plans to have some sub-prioritization in their guidance as well, so that if the doses are limited, as we expect up front, then we'll have additional guidance from ACIP to help us to prioritize within provider groups or healthcare systems.
Okay. The CDC suggested, that there are second waves as well, not just frontline healthcare workers, but long-term care facility people, but people who are, sort of important to society. People who work at grocery stores, healthcare personnel. These will be rolled out later on. Has the CDC gotten any guidance as far as those secondary levels of people who will be administered the vaccine?
I think they fall into that. Some of those fall into phase 1B as essential workers. And the slide that I showed didn't have that level of detail, but listening to the webinar yesterday and reading the slides from ACIP, I know that there are a number of those groups that you just mentioned that are in phase 1B as essential to society to keep everything running. So I know that those are being considered in an early phase.
So I think they were careful to note that the CDC recommendations were just that, recommendations. We need to get to the point about who's next, trying to get more specific about exactly what do we mean by essential workers. Who ultimately makes those decisions in Eastern Iowa?
When it comes down to essential workers, we'll look at things like the ACIP guidance, the guidance the state will provide us as well, and determining and looking at the population specific to Iowa and go from there. But as always, things can change pretty rapidly, but more than likely we can expect that essential personnel are under those federal guidelines of, you can think of critical infrastructure within different workforces of, whether it's energy, transportation, law enforcement, first responders, things like that.
Sam, when you mention we, do you mean the Iowa Department of Public Health?
Yes, the state health department and ourselves.
Okay, all right. And ourselves being Johnson County Department of Public Health?
Yep.
All right, thank you. Some with those doses require 2 doses. Mike, you mentioned that really to be conferred, full immunity, you need to wait until the 2nd dose. For those of us who, really wonder what's going to happen, could you describe to us how much immunity do we really have in those 3 to 4 weeks between vaccines? And then secondly, if we, after we get the 2nd vaccine, when can we really be confident that we're immune?
So I'll speak to that second point first. If you look at the data from the trials where they had maximum efficacy, it was 7 days after that 2nd dose. And I might defer to Dr. Winokur from after the 1st dose, but you do start to develop some immunity. I don't know how much the studies actually measured in between the doses, what the efficacy rate was. So Pat, do you have any thoughts on how much immunity we might have in between doses?
It might be enough to truncate the severity of disease, but I don't think it's going to be enough to really limit spread from person to person. This is, again, the type of data that we'll see more of as the studies are published and see the exact titers, and that'll be a surrogate marker. But I do know that we have had individuals that have acquired COVID-19 between vaccine 1 and vaccine 2. I can't tell you whether they had placebo or whether they had active vaccine, but that's the type of data we'll learn as they publish the studies.
So, Mike, this might be a good one for you. So this is America. We're used to having choices on economics. We actually might have some choices of vaccines going forward when we get to April, May, and June. There will be mRNA that are you get twice. There will be some that you get once, a little less vaccine efficacy, but then again, by then we'll have more herd immunity. Maybe we don't need to be so concerned. And we've heard that people get a bit of a kick after the Pfizer and the Moderna vaccines. A lot of things to think about. Do you think from your pharmacy perspective, do you think that, how would we make those decisions? And do you think those are actually going to be relevant as time goes on?
I think those are definitely personal decisions. If we understand through surveillance after we start to give the vaccine that, maybe there's a little bit less of a reaction with one vaccine, or people have a preference toward 1 dose versus 2. My hope is we have enough stock to be able to manage it in that way. One of our challenges right now is we want to have some vaccine or have enough to get out to our healthcare workers, out into essential workers, those that are of high risk. So at this point, I haven't thought about the choice part of it that much. I think we have to remember that when you have that kick from the vaccine, it's your immune system ramping up, and it means you're becoming immune. So I think we should look at it potentially positively, that type of reaction means that we're getting an immune response and that we're going to be protected against the virus and against serious illness that's caused by the virus. And we don't want anyone to have that kind of severe illness. So, I look forward to that time where we have more choices, and the other thing too is through these studies, we might identify that different vaccines work differently in different people, and we might be able to use that as an advantage too. Maybe for patients that are obese, one vaccine might work better than others. maybe for those over the age of 65. We're going to look at that really closely. It's too early to tell at this point. I'm just excited for the opportunity for us to have enough vaccine for everybody and to be able to get to a point where we do have some kind of choice.
So generally a question for all of you. Let's say I get one of the vaccines that has 95% efficacy. When can I stop taking my wearing my mask? Sam, you're the public health professional. You want to take the first stab on that one?
Yeah, sure. I think as we go forward, I think it's reasonable to assume that early on we'll continue to practice wearing a mask and physically distancing throughout this, and even after the vaccine is widely available. So time will tell.
Mike?
And remember too that the vaccine is not perfect. So especially in some of those vulnerable people, that COVID-19 can be a very devastating illness. We're gonna have to be very careful. And the best of vaccines is imperfect. And 95% means 5% didn't have a great response. And so we're gonna have to really get this pandemic under control before we can move away from the masks.
Yeah, I agree. We need to get control of the pandemic. And we also have to realize we won't be vaccinating kids for a while, and so there's quite an opportunity for spread with children. And, to Dr. Winokur's point, if there's still a possibility that you can become ill from the virus, then we need to continue to wear masks and distance and wash our hands appropriately. And that's going to be important for us for quite a while. The logistics around this are very challenging, and we're not going to be able to vaccinate a large number of people very quickly. It's going to take time, and we really appreciate everyone's patience in that.
Sam, Mike, thank you very much for your presentation. Very helpful. Again, we're going to move on to the third installment. If you all still have any questions and they relate to some of the previous speakers, I'll be happy to have them try and answer as well. The next speaker that we have is Dr. Aaron Scherer. Aaron is a member of the Department of Internal Medicine, and he comes from a slightly different perspective. We've been given all the technical information regarding the vaccine. Now, from a private primary care physician perspective, I really need to know how to talk with people about this. Science is one thing, and as I think we've all found out in the last year or so, science is one thing, but public opinion is quite another. And so Aaron is going to lead us through that. He's a prolific researcher and writer on health systems and public health with a focus on vaccine acceptance. His current projects, which are all very relevant today, include immunization strategies using computer-assisted self-interviewing instruments and online panels of physicians and the public, as well as several NIH-funded projects to create an innovative vaccine messaging for especially our older non-vaccinating adults. He is notably a member of the World Health Organization's COVID vaccination work group on behavioral and social drivers of acceptance of the vaccine to combat this virus. Aaron, thanks for introducing us to the science and language of vaccine confidence.
Yeah, thanks for having me. I'm excited to present this. So, all right. Can everyone see the screen? All right. So when we hear the phrase vaccine hesitancy, people like these vaccine protesters might be what comes to mind. But in reality, only a small percentage of the American public are all-out vaccine refusers or people who oppose all vaccines. And a relatively large swath of the American public is vaccine hesitant, which simply means that they have some level of concern about vaccinating themselves or their kids. Well, one thing I want to clarify is that just because someone does not get vaccinated or hasn't been vaccinated does not mean that they're vaccine hesitant. Being vaccinated or not is, health characteristic It can happen for reasons beyond vaccine hesitancy. While vaccine hesitancy is more of an attitude towards vaccines or your feelings about them. All right, so what do we know about vaccination intentions of the American public? So I think we know both a lot and very little. So we've experienced a deluge of public polling and research on COVID-19 and the public's willingness to get the vaccine. And typically, respondents are asked, if whether or not they'd get a COVID vaccine once it's either available or if it were available right now. But as we've highlighted, there's actually the potential to have multiple types of vaccines that the public might be able to choose from, and they vary on several dimensions. So this raises the question whether people view all the COVID-19 vaccines as the same, or does the type of vaccine impact their willingness to get vaccinated? All right, so just a warning, this will be the one study I describe in detail, but it's relevant given our previous conversations. So to answer this question, some of collaborators and I conducted a national survey with about 1,700 respondents in late September to early October. So one of the things we asked about was their willingness to get a COVID-19 vaccine once one becomes available. So kind of your generic polling question. But later on in the survey, we asked about some of the same questions, but we qualified the vaccine with different characteristics. So we modified, presented the vaccine on different vaccination schedules and dosing, as well as approval conditions. So when we asked about a generic COVID vaccine, about 59 out of every 100 respondents indicated they'd get vaccinated once the vaccine became available. And this was pretty consistent with other polling that happened at the time. However, we see vaccination intentions drop 5 to 6% if we asked about a COVID vaccine that required more than one dose. So we asked about a 2-dose vaccine, getting a booster after you turn 65. We asked about an annual vaccine. And also we see a drop if, we ask them, if it's available in 6 months. Now, 5 to 6% may not sound like a lot. A decrease of only 1% in the COVID vaccination rate means that there would be roughly 3.3 million people who would no longer get the vaccine who would have otherwise. So it's pretty significant when you consider 5 to 6%. With that in mind, it's even more troubling that we saw vaccination intentions drop by 17 to 19% if the vaccine were released in a month or through an emergency use authorization from the FDA, which we've discussed. And I'll touch on why that may or may not be concerning in a little more detail later. But we also asked every respondent to imagine that they decided to not, if they decided to not get the COVID vaccine, what their primary reason would be. And roughly 11% of respondents said the primary reason they might not get the COVID vaccine was because they're opposed to all vaccines. So given that large gap between the percent of respondents who were vaccine refusers and the percent who said they would not get the vaccine or were unsure about getting it, that gap highlights that, COVID-19 vaccine hesitancy occurs for other reasons just beyond total opposition to vaccines. Rick wanted me to plug this. So Johnson County is conducting a survey right now on trying to get a read on vaccine attitudes and intentions around the COVID-19 vaccine. Got a QR, I put in a QR code. I haven't tested it, but hopefully it works. So if you can, ideally can scan that and take that at your leisure. All right, so why wouldn't adults want to get vaccinated against COVID? As I mentioned at the beginning, there are reasons why a person might not get vaccinated besides vaccine hesitancy. Some of these reasons are structural barriers, meaning that a person's unable to access vaccination services, even if they wanted to be vaccinated. So examples of structural barriers include not being in a vaccine eligible group, financial cost incurred to get vaccinated, as well as, just not having the time to go to a vaccination site. But most of the barriers that we see towards getting vaccinated are psychological in nature, including, believing that you won't get the disease, or that if you do get it, it won't be that bad for you. And, as we've encountered, there's lots of reasons and beliefs and feelings that people have about vaccines. But essentially they kind of boil down into three categories that are relevant. So there's people's kind of subjective weighing of the potential harms and the potential benefits of being vaccinated. There's a level of trust in the safety and efficacy of the vaccine. So that's more of a kind of feeling about safety. And then people's level of trust in organizations responsible for the creation, distribution, and administration of vaccines. So including, pharmaceutical companies, or all the way down to your primary care provider. Your level of trust in those organizations and people also is relevant. Finally, there's a growing body of evidence highlighting how general psychological traits, so the traits that aren't linked explicitly to vaccines, how different psychological traits are associated with either more negative vaccine attitudes or non-vaccination. So some examples of these include, how comfortable a person is with ambiguity, as well as their level of concern about potential moral or physical purity violations. All right, so now we come to the $1 million question. So as employers, what are things that you can do to promote vaccine uptake among your employees? One thing you can do is make getting vaccinated as easy as possible for your employees. And there's a number of things you could do to make that happen. So one is to offer on-site vaccination. This has been shown to significantly improve vaccination rates. Another way of doing this would be providing incentives for getting vaccinated. And, if you do have financial incentives, you might take a short-term hit financially, but it'll pay off in the long run because you'll prevent all the larger losses you'd incur in lost productivity if people ended up getting infected. Conversely, you can make things more difficult for employees who choose to not get vaccinated. So you can do things like make non-vaccinating employees wear extra personal protective equipment. So, during flu season, at the hospital, if you don't get vaccinated, you have to wear a mask. Now it's kind of a non-issue with COVID, but, or you could do something creative like temporarily reassigning non-vaccinated employees to a less desirable part of the building. And then the final thing, which has been highlighted, Dr. Winokur highlighted, the COVID vaccines, at least the mRNA ones, can induce such a strong immune response that a small percentage of people may experience, short-term side effects after vaccination that may lead them to take a day or two off work. And as a result, some employees, especially like hourly employees, may decide to not risk missing a day or two of work to get vaccinated because of the potential lost income. So to address this, you may want to provide extra paid time off or sick leave to employees, so that doesn't serve as the barrier to them getting vaccinated. A second thing you can do is leverage our social nature. So, we're social animals, and that can be used in ways to promote vaccination. One example includes having a respected leader of the company or a respected member of an employee group like a union publicly announce their support for the vaccine, or getting vaccinated in a very public way that the employees can see. We also tend to do things that we think our groups are doing. So vaccination rates are, among your employees is relatively high. You might want to emphasize that so that other people in the company know that their coworkers are being vaccinated. And finally, one of the things that you can communicate to employees is that even if they don't think they're at risk of developing severe complications if they got COVID, they might unknowingly pass it on to someone who is. So as a result, we've highlighted this, getting vaccinated just doesn't protect yourself, it protects other people in the company, as well as people you care about, such as friends and family. And then a third thing is using best practices when we communicate about COVID vaccination. So the way in which you communicate information about the vaccine or about anything really may have a larger impact on your audience than you may realize. And so I'm going to highlight some strategies to think about when you're communicating about COVID vaccination with your employees. One thing that's important to do is add contextual information. So one common communication mistake is the assumption that providing people with facts and numbers is the same as providing them with information that they can understand and use. So just to give you an example, imagine you got this platelet test result of 135 times 10 to the 9th liter. Unless you have regular testing to monitor your platelet count, it's hard to know what this test value really indicates about your health. Is it good? Is it bad? Is it okay? And presented in this format in a table, only about half of people can correctly identify whether their test result is in the standard range or not, much less whether their result indicates anything good or bad about their health. And so some of the research I've done in the past has demonstrated that simply putting a clinical test result on a visual number line, like the one displayed here, improves people's ability to interpret values near the standard range from those that are more extreme. Now I want you to imagine reading the following headline about the recent preliminary data from Moderna's COVID vaccine clinical trial. By only focusing on the number of negative events for the vaccination group, this headline might inadvertently bias people away from getting the vaccine once it's available. And so pictographs improve understanding of information, particularly among individuals with low numeracy or the ability to understand and use numbers. And as you can see here, while 11, might make you think about, well, it's not completely protecting people. When you look at the number of COVID cases in the vaccine group compared to the no vaccine group, you can see how well it protects individuals from COVID. Another thing you could do is be intentional about using gain or loss frames. So the two statements on the left are mathematically equivalent. 6% of people who are exposed to someone with COVID but have been vaccinated will get COVID. 94% of people who are exposed to someone with COVID but have been vaccinated will not get COVID. So those are mathematically equivalent, but psychologically they're very different for people. When you highlight potential harms that occur, people tend to play it safe and avoid risky options. Whereas when you highlight the potential benefits or gains of something, people are less, more risk taking. And so they might be more likely to do something like get vaccinated if they perceive that as a risky option. And then you can capitalize on focalism by using narrative. So focalism is a bias that we have to where we kind of focus in on one option and either minimize it or ignore information about other options. And so narratives are a super powerful way of communicating information. And this has been kind of weaponized by anti-vaccine groups because narratives tend to be more persuasive than statistics. And so as an example, we can use targeted narratives of a patient who had a severe experience or experienced a severe case of COVID. Versus if you present both sides, people tend to kind of tune in the side they're motivated to believe. All right, and now I'm going to quickly wrap up with a few other things to consider. As we noted, people are going to still need to engage in other protective behaviors when the vaccine becomes first available until we get a sufficient level of vaccination. And to promote these protective behaviors, I recently did some research that suggests that we should use the term physical distancing, as it increases people's intentions of engaging in distancing practices kind of relative to those other terms. And also discussed, we need to be aware of the challenges that will occur logistically in terms of the distribution and storage of the vaccine. And we need to make sure to be aware of ways that we can kind of distribute the vaccine in equitable way, both across marginalized groups as well as in rural areas and other groups who might not be able to have access to it. And then the phased rollout of the vaccine might actually be helpful in terms of promoting interest in the vaccine. As we, highlighted, as I highlighted initially, there's a huge drop if it was issued on, within a month or had emergency use authorization. But people tend to want something more if they believe it's scarce, which could work in our favor, as well as the fact that, as has been brought up, once you start seeing more people who've been vaccinated and they're fine, it might increase people's comfort with it. And finally, I just want to highlight how it's natural to become less empathetic towards people who don't believe the same things that you do. However, to end this pandemic, I'd encourage you to be intentional with how you interact with people who might be vaccine hesitant. It's really easy to forget that, most of us are genuinely trying to do our best to do what we think is the right thing, even if we might be on opposite sides of the vaccine debate. So these are 3 key takeaways. I threw a lot of stuff at you. If you take away anything from this, I hope it's these 3 things. And I think I'm over time, so I will open it up to answer some questions.
Aaron, thanks a lot. I have some interesting questions. One question regarding, wouldn't penalties put the employer at risk for civil discrimination lawsuits? I'll give you a specific example. From the United Auto Workers, there's from Dr. Darius Sivan with the UAW, there's strong support for encouraging vaccination through measures like providing vaccines on site. I really question the morality and efficacy of punishing workers who choose not to get vaccinated. Workers of colors have legitimate reasons to distrust the medical establishment. Some people are allergic to the albumin, which could be an adjuvant in many of the vaccines, or they may be just simply misinformed. What would you have to say about concerns about the categories of actual penalties and punishment?
Yeah, obviously I'm not a legal expert, but I tend to err on the side of using the carrot, not the stick when it comes to vaccination. There's been talk about mandates, but I think, mandates might be effective in the short term, but you could potentially damage vaccine attitudes in general when you implement them. And so I'm more in favor of, using strategies that really kind of promote vaccination, as opposed to penalizing people who haven't gotten vaccinated.
And by the way, in anticipation of this question, I did talk with our legal department here at the UIHC. The recommendation regarding mandates is for all employers and organizations is that you contact your standard legal assistance that you have. I know many not-for-profits will sometimes have a lawyer who is on your board of directors to answer this sort of a question regarding the legality of mandates about the COVID-19 vaccine. The caution that I was given was that if you are a strict healthcare facility, there may be some possibilities to put on some level of mandates, but if you are not a fairly strict medical facility, the medical ability to put out a mandate is questionable. but he said consult your own lawyers available to you. So Aaron, another question that came through is that, I couldn't even talk to my friends and my families and my coworkers about my choice for president. So how on earth could I approach getting the vaccination when I feel as strongly about this as I did about who I voted for president?
Yeah, that's a good question. I think this is where my last point comes into play of, if both sides are acting in good faith, I think it's possible to be respectful and have good conversations. I think the problem, with politics these days is that people act as if they want to engage in dialogue when in reality, they're coming in bad faith and don't really care about having an honest discussion about it. And so, but I think for those people who, have genuine questions and are acting in good faith, that simply just, being respectful and trying to cultivate a healthy relationship with that person is the best way to go. Trust is like one of the main indicators for people's willingness to get vaccinated. And so I think just, cultivating trust with people is one way to go about that. So that's kind of the route I would go. But obviously everyone's situation is different. So.
Thanks. Another question is, I do not have Dr. Dan Fick. He's the campus health officer for the University of Iowa. But a question that came in, does the University of Iowa plan to, what are we going to use for students to encourage them to get vaccinated? Aaron or others, do you have any ideas?
Yeah, I have no idea what they're going to plan for. I imagine offering, making it available, easily available, but I don't know exactly what they're planning.
My sense, Mike Brownlee, is that given the availability of vaccines, most of our students here at the University of Iowa are low risk. And so I think that they would be much later in terms of the wave of vaccines. So that probably wouldn't happen until May, June, or deep into the summer.
Yeah, it may be when they're actually back home if they leave. We do have student workers that work for us. I think having our student workers that work for us as healthcare workers receive the vaccine and then be able to tell other students about the positivity of receiving the vaccine with us might be a motivator within those groups. We have actually vaccine champions on campus within some of the health science colleges. I think having them speak to that as well would be a positive way to send that message to students. But I think to your point, they're going to be pretty late in the process from a vaccination perspective.
So Sam, for you, is that from a public health perspective, and the rest of the speakers, if you could also mention, if we wanted to send somebody some information regarding the vaccine that we think would be applicable to whatever concerns that they have, are there innovative sites that they could go to? And I'm talking about a broad array of social media platforms, even things that as a baby boomer I can't even pronounce. Are there any suggestions that any of you have that people could go to, that might give a short, brief, maybe even entertaining and innovative reason to perhaps consider the vaccine based on what Aaron mentioned?
Yeah, thank you for the question. As we go on, it'll be really important to get the information from appropriate sources, because we anticipate there will be a lot of misinformation out there as well too. But in terms of innovative ways, I think we'll see going forward a lot of influencers on social media, whether it's Instagram or TikTok, doing different dances and things that I've tried and hurt myself on, at home and everything. So I think stay tuned. We'll see a lot of different information coming out, but we're hopeful that things like that really appeal and kind of highlight the importance of what this is, not just for themselves but for their friends and family too.
Yeah, I haven't come across anything. One thing talking about misinformation I want to highlight is in a recent study, I found that 7 out of 10 people in our study endorsed at least one conspiracy about COVID out of 7 possible conspiracies. And 2 out of every 10 people indicated some level of agreement with the phrase COVID-19 is a hoax, in parentheses, not real, which is a little bit sobering. And I think that, and this is something that I argued in a recent grant that got funded, is that I think our problem is that, we come at this as if there's an information gap problem, that if we just give people the right information, then they'll do the right thing. But as I highlighted, a lot of this is going to be rooted in different psychological needs that are being met. So it might be that, people feel that there's too much uncertainty out there, and so they latch on to stuff that makes them feel more certain, or they feel a loss of control, and so that's what they latch on to. And so I think identifying kind of what the underlying kind of thing that may be going on with people will be better for helping address their concerns about COVID vaccination, as opposed to just giving them kind of information about it.
Okay. Mike, how much is the vaccine going to cost?
Great question. It's free. So there may be some administration charge, but per the federal government rules, we are to provide it at no charge, even if someone cannot afford the vaccine. So Sam, I don't know if you want to mention anything else related to that, but our intent and plan right now from a healthcare provider is to provide to everyone that we're able to. I think that's consistent with the guidance from Johnson County Public Health and IDPH. Sam, did you have any other thoughts?
No other thoughts, and absolutely, and we hope that as many barriers as possible to the public are eliminated, so we can see everyone get this.
So thank you all to the speakers. Mark, I was wondering, except possibly for Aaron, all of us are sort of science geeks. From a more community perspective, is there any question that you could have on behalf of the audience that you could ask any of the speakers?
You're on mute still.
You're muted.
There's always that one person. I appreciate the question. I hope everyone had a chance to get their questions answered. I think, and we mentioned this, we'll do a second round of this, sometime January, February, after the vaccine's out a little bit, and people are starting to get some data. My sense is when people start getting vaccinated and maybe experiencing some of those symptoms, and that's when we're really going to need to come back together and figure out messaging and dispel any myths and rumors that might be out there. So I appreciate the question. I don't know right now. I think the way you've all presented the information to us lay people has been very helpful. So thank you.
Well, Mark asked me to make some closing remarks. As I mentioned earlier before, is that this has become more of a personal nature for me. I'm an older physician here at the UIHC. And I've watched while my colleagues in internal medicine, physician and providers, nurses, respiratory therapists, all the ancillary healthcare providers have provided direct care to our COVID patients here at the UIHC, similar to what our colleagues around Eastern Iowa have had to do. And I've been extraordinarily impressed. It's very different now that I myself am starting to take care of these patients. And what I've seen about them, and this is for someone who's been in medical practice for over 30 years, has worked in hospice and end of life. I've intubated people who are in acute respiratory failure. And from a personal perspective, what I've seen over the last few weeks, watching our inpatients who have become more advanced in terms of their acute respiratory needs, is this is a very different infection than anything I've ever seen before. One of the, I guess, hopeful things about when someone is what they can no longer breathe is that the brain begins to slow. It begins to shut down. We call that hypoxic encephalopathy. And in some ways, that's sort of a kind way when someone is beginning to drown and they can't breathe anymore. there's something referred to in the humor of medical providers as happy hypoxia. That's particular to COVID. It's when a patient who has the infection in their lungs does not really feel that they're getting out of breath, but the demonstrated lack of oxygen when you put a pulse oximeter on their finger says otherwise. That tells you very quickly how happy hypoxia can go to not very happy at all. It's so fast that I've seen these patients, and as opposed to other patients in acute respiratory failure in my career, they are very much aware of what is happening to them. It actually makes me think of waterboarding and the fact that people, as a form of torture, are being administered on a mask over their face, the drip of water, and they're very aware that they cannot breathe. COVID is very different. It installs a sense of intensity, emotional intensity, that I think the patients and those of us who take care of them feel here and at all the hospitals and facilities in Eastern Iowa. Because of those emotional intensity, when we're faced with someone who doesn't want to take the vaccine, it's hard to control one's emotions. But I would take something that Aaron Scherer has talked to us about, and what it is active listening. Listen to the person, hear what their concerns are, try not to expound on the intensity of emotion that we ourselves might have. That's probably the way that we all need to talk to our colleagues, our friends, and our employees that don't want to get the vaccine. As Mark noted, we're going to redo this again in a couple of months. I hope this has been helpful to all of us. And I would thank our speakers, presenters, for providing a lot of information and answering all our questions. And thank you very much.
Thank you, Rick. Again, our thanks to all of you for being here. Thank you to the healthcare workers for all that you're doing every day. Again, we'd ask people to go to icareatogether.com to adopt a healthcare worker, find out what you can be doing to provide some just kind of mental health support to those that are on the front lines right now. So thank you, everyone, again. Thank you, Rick. Great job, and be well.